شكرا للأخوة المنظمين نكون معكم إن شاء الله اليوم. Hopefully إن شاء الله everything would be fine and you get some sort of good informations. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. Okay, I have two slides, which is almost every lecture with rheumatologists I keep them, that we should know about our goals, pathophysiology of rheumatology or inflammatory arthritis. Our goal in this whole or in the working environment that we should diagnose as soon as possible or as early as possible the disease and act on management to shorten or reduce the complications. I second Dr. Hussam about the multidisciplinary opinions or decisions should be taken and should be taken seriously in all of the hospitals, as a matter of fact. So radiology has a role as well in the diagnosis and probably part of the management of the inflammatory arthritis. This is one of the important issues which I will build all of my talk on. So if we know that inflammatory arthritis / rheumatoid arthritis, etc., is a synovial disease to start with. So it might go for the hyperemia, synovial proliferation, or joint effusion, joint pathology. So these are the aim of my lecture. So I will cover most of these 9 items. So if you just categorize the cases which I will present, they will go through developmental, traumatic, metaplasias, tumors, infection, inflammatory, metabolic, hematologic, and vascular. So we'll get at least one case from each one. This is an 11 years of girl with a thick chronic mass at the suprapatellar bursa. I think this is the, okay. So this is the frontal projection of the left knee. This is the lateral projection of the same knee. What we really see, we see a soft tissue mass in the suprapatellar bursa. On examination, this mass is rubbery. So we did MR for this patient. What we really have is that a synovial plica isolating the superior plica or suprapatellar region from the inferior region. So we know that we have 3 compartments in the fetal life. Before the delivery, these compartments merge to form one synovial sac. So this one has persisted and formed a chronic mass-like lesion. The only treatment is surgical fenestration of the synovial plica. Otherwise, it might bleed, inflamed, synovitis, etc., etc. So they call it as a synovial compartmentalization of the suprapatellar bursa by this plica syndrome. We have other plica, which is the infrapatellar plica. We have the suprapatellar plica, lateral plica, medial plica. All of these are asymptomatic except the medial one. So the medial plica is the one which is really symptomatic, and most of the patients, they come with the pain in the medial aspect, anterior knee. A patient which is known to have Down syndrome, knee pain and swelling, and you can see this much of soft tissue density in the suprapatellar bursa. The overall bone density is reduced. The Down syndrome goes with the osteoporotic changes. The patient had a chronic or old healed fracture of the distal femur, and there might be an element of the chondrocalcinosis in this area. This is the MR for the same patient, coronal T1, coronal stir. What we really see, we see that fluid with the thickened small nodular regions of the synovium here, as well as there is a physial bar, which might need to be intervened surgically. So what you really see sequelae of previous trauma, changes of osteoporosis, and chronic synovitis. This patient is Down syndrome. That means they have a ligamentous laxity. So this patient had a frequent, recurrent knee dislocation or the patellar dislocation and relocation. And you can see significant fluid is seen in this area. And what you really see, that the medial patellar retinaculum is torn. So that means that this goes with more with the orthopedic surgeon, not with the rheumatological management. What we really see as well, we see, how can I go back? Okay. And we can see that this ACL is sprained because of this laxity and the chronic manifestation of the synovitis. Aspiration proved that this is a hematoma or hemarthrosis. The same sequence of a trauma, this is a very diagnostic layering of the hemarthrosis. You can see the precipitate of the cellular part of blood, and this one is the plasma or the fluid, which is more lighter. A patient which is a middle age with diabetes, swelling of the knee, these are the x-rays. What you really see here is that multiple innumerable calcified particles or loose bodies. These are all over from the anterior, superior, and also the posterior aspect of the knee. So what we really see here is that this is the coronal and sagittary formats. By CT scan, you can see them as rice bodies, and they are calcified with a significant distension of the joint space as well as the posterior aspect of the knee. So these are primary or secondary synovial chondromatosis, synovial osteochondromatosis, because they are already calcified. How can we differentiate between the primary or secondary synovial osteochondromatosis? Is this one. If you see secondary degenerative changes, this is a secondary synovial osteochondromatosis. If you don't see any evidence of the degenerative changes or osteophytes, this is primary type of synovial osteochondromatosis. Some sort of new or recent technology, we can do the bone marrow mapping, gout mapping. These are all negative. But what we know that if you see the purple color, this is more towards the pyrophosphate calcium, or CPPD, calcium pyrophosphate dehydrogenase deposition disease. So it's more towards, not towards the gouty arthropathy. Another patient, which is a really interesting case, middle age, she was a female, but this is a type of mistake. Came when presented with the suprapatellar bursal mass lesion. Interestingly enough, that on plain X-rays, that there are areas of low density. What we know, that low density either to be fat or air. So this might be an air locules or fat globules. So the only answer here, either you do CT to check for the air, or you do MRI to check for fat. From the density here, it seems that it is closer to the fat rather than air. We did the MR for this patient. T1 weighted, subcutaneous fat is bright. This is the inside of the joint and rice bodies, but they are as well bright. Fat suppression, low fat, so these are the globules of fat, which seems to be intrasynovial. So what are these? Intrasynovial fat proliferation, which is a metaplasia of the synovial fat. This is lipoma arborescens, and can cause secondary degenerative changes and can cause as well synovitis. So after the injection of the contrast, you can see the synovial enhancement. So this patient might go towards the synovitis as well with the degenerative changes. So we should know about this item, which is the metaplasia or hyperplasia of the synovial fat, lipoma arborescens. 21 years old female patient, knee pain. This is the X-ray. Wherever you go for the rheumatoid arthritis, they will mention about widening of the intercondylar intercondylar notch. So this one, an intercondylar notch widening? It's not. Why? It's very bordered with the sclerotic margin, with also sclerosis. So this is against that this is the widening of the intercondylar notch. We did the MR for this patient. It is epiphyseal lesion, cystic, fluid levels, and significant juxta-lesional or regional edema. So these are very characteristic in a young patient, epiphyseal lesion, mass lesion, with the sclerotic margin, probable some sort of areas of chondroid region. So these are going to be more towards chondroid tumor. If you see a tumor, which is like this one, I call it as the coral type of image. It's like al-murjan, shu'ab al-murjan. Like this one, it's like the coral island. Mass lesion, destructive, with a significant, huge edema. This is chondroblastoma unless proved otherwise. Osteodysteoma doesn't grow as much as this size. Osteodysteoma maximum diameter is 1.5 centimeters. So this one is a huge subchondral epiphyseal lesion with edema. This is the enhancement of post-contrast, and you can see a secondary reactive synovitis with this mass lesion. So this is definitely a tumor case, chondroblastoma, which needs to be furtherly treated using the surgical techniques. This is an interesting case, 32 years old man presented with left knee pain, swelling for 8 months, recurrent. So from this one, what we really see just a small areas of lytic changes around the knee joint, low densities. MRI, and I have too many questions about the how can you differentiate between synovitis and septic arthritis. So I will give you one of the tricks. If you have a case with septic arthritis, you should have a peri-synovial soft tissue edema and reaction. This goes more with the septic arthritis. If you see areas of bone marrow edema and enhancement, this is septic arthritis unless proved otherwise. The soft tissue edema is more specific compared to the edema in the bone marrow. Why? Because of the pannus impressions on the cortex rather than impressions on the soft tissues. So the inflammation around the synovium goes more towards the septic arthritis. So this tends to be septic arthritis and mimicking definitely for long time chronic, long time manifestations of knee pain. This is a patient which you can see that if you lose the cortex of a bone, it means osteomyelitis unless proved otherwise, and the same sitting. Focal form of PVNS can mimic definitely the synovitis and rheumatoid or rheumatological manifestations. The PVNS, pigmented villonodular synovitis, can be generalized form or a focal form. The focal form, they call it giant cell tumor of tendon sheath, and you can see that the enhancement or the edema or the blooming of the mass because of the chronic manifestations of bleed. So this is hemosiderin deposits would be bloomed, and it will be more dark compared to the rest of the tumor components. Nursemaid can be presented as swelling around the knee joint. We shouldn't be mistaking it with the joint effusion. So be careful to label that this is a joint effusion with a tapping sign or something like that for the joint effusion because of this prepatellar fluid accumulation. This is prepatellar bursitis rather than synovitis. We have another patient which is really interesting here. Bone density is normal, mild reduction of the medial joint compartment, but what you really see, the doubling cortex here, or the articular surface. This is one point. The second point is a very, very faint calcification in here. I'll magnify it just to show it more. So you can see this faint calcification of the soft tissue. We have a special techniques nowadays. What we are really doing at the CT scan dual energy for the calcium deposition or monosodium urate crystal deposition. And what you really see, you can see this fluffy calcifications within and around the knee joint. So we did the dual energy CT, and you can see the green areas here, these globules of monosodium urate deposition, crystal depositions in multiple regions. This is the hiatus, popliteus, and around the ACL, and also about the insertion of the lateral collateral ligament. So this is diagnostic, and you can act on for gouty arthropathy. Hemophilic patients will present similar as TB, as also as the rheumatoid arthritis, in exhibiting the widening of the intercondylar notch. But if you see destruction of the joint like this, you should think about the hemophilic arthropathy. And hemophilic arthropathy are too many grades, and it is really at the end stages here, you will see that burned out joints and synovium. And you can see that the subchondral cystic changes with destruction of the joint with significant subchondral edema and probably sort of cystic change. أنا سوري ترى باقي كم الوقت؟ خلصنا ولا باقي؟ 5 دقائق؟ جزاك الله خير، شكرا. This is a mass in the suprapatellar bursa in the left side as well. MR is showing bright signal intensity on stare, isosignal intensity, and it is like a leaf. This one is an extra synovial hemangioma, and we did the angiography and embolization for this case, and everything has resolved. This is an interesting case, and this is the last case. This is a patient which is known to have rheumatoid arthritis, poorly controlled. So presented with significant pain, destruction of the joints. You can see the erosions, subchondral cystic change, and also erosions in here. These are all goes with a uniform joint space narrowing. Everything goes with the synovitis and rheumatoid arthritis. This is the geode. These are the changes of erosions. But what happened in this case, we did open the gate only, and you can see that there is intramedullary lesion in the distal femur, intramedullary lesion in the proximal tibia, and T2 or PD fat set, and T1. You can see them very low, but not as low as a fluid. So what we know that intraosseous rheumatoid nodules can happen in these cases, but not in this region, number one. Number two, it should be a cystic component rather than a soft tissue component. A cystic component should be less signal intensity, very low signal intensity compared to the muscles, that this one is more towards the soft tissue rather than cystic. So what is this? In a poorly controlled rheumatoid arthritis patient with intramedullary lesions, we know that rheumatoid arthritis can be associated with malignancies. So think all the time with the complications and other associations with the inflammatory diseases, especially rheumatoid arthritis, poorly controlled with bone marrow lesions. This patient tends to be lymphoma. So it's very important to know the diversity of complications which can happen in the inflammatory arthritis. Thank you very much.